Boa noite a todos. É um enorme prazer iniciarmos mais uma sessão da SOBED Nacional, onde vamos abordar os erros e como evitá-los no esôfago de Barrett, em que nós teremos a presença do professor Pratek Sharma, professor da Universidade de Kansas, e ele é um gastroenterologista, hepatologista e também age na área da motilidade. Professor Sharma, good evening, everyone. Today, I am pleased to introduce Professor Pratek Sharma. He is the most renowned gastroenterologist focused in Barrett's esophagus. I'd also to introduce Dr. Vitor Arantes from Minas Gerais, Belo Horizonte, and Dr. Dalton Chaves from São Paulo, who will be the moderators of the session. Thanks, Professor Pratek Sharma, my great friend. Thanks for accepting our invitation. It's very important for us. Thank you. Go ahead.
Okay, Eduardo, thank you very much. And, my thanks to Eduardo and Sobed for asking me to participate. And I really enjoyed trying to put this thing together, because errors in management or errors in approach is something which is very unique. And in fact, as I was putting this thing together, I ended up learning a little bit as well. So Eduardo, can you see my slides? Everything's good?
Oh, it's perfect.
Yes? Okay, excellent. So I'll get started with it. And when you look at errors in management in Barrett's esophagus, there may be two different types of errors. One is, as an endoscopist, you have an error in the diagnosis. So you're not able to diagnose Barrett's esophagus appropriately. And the second can be an error in treatment, so that you have the appropriate diagnosis, the patient does have Barrett's esophagus, but you're not appropriately managing the patient. So I'll spend time in separate ways talking about the errors. So let's start off first with the errors in diagnosis. I've listed these errors in diagnosis. You can go on a little bit more with this list, but I thought that these, from a very simplistic and a practical standpoint, these would be the major errors in diagnosis. Number one is diagnosing the irregular Z line or the Z line or the squamocolumnar junction as Barrett's esophagus. The second would be not inspecting the Barrett's esophagus carefully. Third is failing to recognize a hiatus hernia in a patient who has Barrett's esophagus. And the fourth is obtaining biopsies without any evidence of Barrett's esophagus. So let's look at all of these things one by one and trying to figure out how these fit into an error. So this is a simple example of what should not be called Barrett's esophagus in my mind. So this is a good example. I'll pause the video here, and you can see that this patient has the gastric folds coming right up to the squamocolumnar junction right here. And you could argue that this fold stops here. But in all reality, this is not truly Barrett's esophagus. And if you were to take biopsies from that area, as is mentioned here, you may find intestinal metaplasia, but I think this is overcalling Barrett's esophagus. This may represent intestinal metaplasia of the stomach or the gastric cardia and not true Barrett's esophagus as well. What's the reason I say that? Number one is that now the updated definition of Barrett's esophagus says that for you to call a length of more than 1 centimeter should be the minimum length before you start calling somebody as having Barrett's esophagus. So this is an important concept to remember. The second is that these short or irregular Barrett's very infrequently progress. This is a large study that we published in Gastroenterology a few years ago, in which we took patients with NDBE or no dysplasia at baseline. And 167 of these patients were with a length of 1 centimeter, less than 1 centimeter. So very similar to the endoscopy examination I showed you. When we followed them up for 6 years, none of them progressed to high-grade dysplasia or cancer, whereas all the incident cases that we found were from Barrett's, which had a length of greater than 1 centimeter. Now, several people say, well, I've seen Barrett cancer in a less than 1 centimeter. Yes, you can. So if you see something abnormal when you're performing the procedure, yes, of course, you should biopsy it. Here we are talking about something which is absolutely normal. The patient has a hernia and you're trying to biopsy that. The second is inspecting the Barrett segment. So if you do have true Barrett's, how should you inspect it and why is it important? This is a meta-analysis published in Gastroenterology about 4 years ago from a study by the Mayo Clinic investigators. And their question was, how many of all the Barrett's cancers which are reported happen within the very first year of the index endoscopy? So just think of gastric cancer, colon cancer, any of the luminal cancers. You perform an endoscopy today and you say there is no cancer. The patient comes in within 1 year for some symptom. You perform the colonoscopy and you find a colon cancer. Well, that was a cancer that we probably missed at the first endoscopy. And in Barrett's esophagus, this number is about 20%. So of all the literature published, about 20% of all cancers were diagnosed within the very first year of the index endoscopy. And so this is why we need a very careful examination. You need to make sure that you have cleaned the esophagus very nicely. You're doing a very slow pullback of the esophagus, and you are inspecting the mucosa very carefully. I'm saying this for Barrett's esophagus, but this is true for colon cancer, for colonoscopy, for gastroscopy, for everything. Now, in this same example, if I will pause again, what I will show you is that there is an early Barrett's cancer in this patient. And that was in the 12 o'clock position. And I'll try to pause it, hopefully this time appropriately, and show you that in the 12 o'clock position, you could miss an early esophageal cancer. This is it right here in the 11-12 o'clock position. So detecting lesions can be difficult in patients with Barrett's. So a common error which is made by endoscopists is doing a very quick inspection, not washing the esophagus, trying to do an upper gastroscopy in 2 minutes and saying, see how fast I am. I can finish an upper EGD in very quickly for that. This is the Barrett's inspection time. This is the amount of time spent inside the esophagus examining the Barrett's mucosa. And you can see that as the inspection time increases, as you go from the left to the right, this is the percentage of patients who are diagnosed with lesions. If you do a very quick exam, your inspection time is low. This is visible lesion detection, and you can see how it can improve very high if you spend some time inspecting the mucosa. Next is failing to recognize a hiatus hernia. And this is important. This is a recent study of close to 4,500 patients with Barrett's esophagus. And what this shows is that there is a very strong association between the hiatus hernia and Barrett's esophagus. And that can sometimes be tricky. Look at the image on the left. This is all the hiatal hernia. Don't biopsy here. This is the diaphragmatic pinch. And this is the GE junction right here, the top of the gastric folds. So everything above this is the Barrett's, not this. This, wherever my arrows are, all of this is the hiatus hernia. So make sure that you are able to separate the hiatal hernia from the Barrett's esophagus when you are doing that. And finally, of course, obtaining biopsies. If there is no Barrett's, don't do that. You may say this is all well and good, but does it really actually make a difference? And can you actually improve? And the answer is yes. This is a study from England in the UK, What they did is they looked at two separate groups of endoscopists. On the left in green is group A. These are trained endoscopists. So these are people who have been taught about the Prague classification, the Seattle protocol for biopsy, how to detect lesions. On the right is group B, who are general endoscopists who went through a regular training without any specific Barrett's training. Let's see what the differences are. More endoscopists in group A followed the Praga criteria. More of them did better biopsies, and this translated into more dysplasia and cancer being diagnosed by the endoscopists who were better trained rather than those who did not pay attention to the Barrett's. So, diagnostic errors do happen. All of us make it. I make it as well. But the good thing is that if you train yourself, you educate yourself, you can do better and you can avoid these errors in diagnosis. So now the second part is related to errors in treatment. Is what are the errors in treatment that we can do in our patients and how can we avoid that? First is too frequent endoscopic surveillance. So you know that one of the ways we manage Barrett's patient is by surveillance endoscopy. So every 3 to 5 years, you bring them back and you do surveillance. Number two, if you are treating a patient, not performing EMR or endoscopic resection or ESD of visible lesions. Number three, if you are doing Barrett's endoscopic therapy, not achieving complete eradication of Barrett's esophagus. And number four is not recognizing and treating complications. So these are some errors in management, and let's look at each one of them and see how we can improve as an endoscopist in doing that. This is a recent study from the Netherlands, and I collaborated with these investigators, and what we did is we looked at 56 studies, 14,000 patients with Barrett's performed by close to 5,000 endoscopists. And we looked at how many endoscopists were following the surveillance interval according to the guideline. For non-dysplastic Barrett's esophagus, only 55%. Low-grade dysplasia patients, only 50%. How many endoscopists of these 5,000 were following the biopsy protocol? Only 50%. So, all throughout the world, we are not doing a good job in adhering to the surveillance guidelines. And I think we should do a better job in doing that. So, what are the guidelines? The guidelines recommend that if you have no dysplasia, surveillance should be done no sooner than 3 to 5 years. So it gives you a little bit of a range. If you have somebody with more risk factors, you can do 3 years. Less risk factors, maybe even 5 years. Low-grade dysplasia, initially every 6 to 12 months, and then you can go every 12 months. So this is what the current guidelines recommend. How will we be doing surveillance in the future? I think we will be doing it based on some sort of a scoring system. So personalized medicine. What do I mean by that is look at this study, looking at close to 3,000 patients with Barrett's esophagus. And what they did is that they looked at risk factors and gave each risk factor a score. So males, cigarette smoking, length of Barrett's, 1 point for every length, confirmed low-grade dysplasia. So these were the points which were given. And then if you look at the points, they correlated with the risk of progression. So as the points increase, your risk of progression also increases. So in the future, what we'll be doing is we will be calculating a score for the patient. So you can imagine you have a male patient who's a smoker, has a 10 centimeter long Barrett's, and also has low-grade dysplasia. That patient will be a high-risk patient. And then you have to be concerned about progression. On the other hand, if you have a young female who's a non-smoker, has no dysplasia, and a Barrett's length of 2 centimeters, that's a very low-risk patient. Perhaps in the future, we can just do endoscopy in that patient like every 10 years. Maybe you don't even need it every 5 years. So this is how we will be doing surveillance in the future. How about now endoscopic therapy for cancer or high-grade dysplasia? The first is EMR. It's very important to recognize that if you have a lesion, which is seen right here, is you should do a resection. Do not take a biopsy, too much of it. Do not do ablation of it, but resect it. This is looking at it with the CAP technique of Inoue. You inject saline and then you resect it with the help of a snare. And what you have done is removed a 2 centimeter lesion, and you're looking at the area after the resection has been performed. Why should you do it, and why is it an error not to do resection? Firstly is diagnosis, and this is that resection specimen on low power microscopy on the top and high power on the bottom. And what you can see is that there is cancer, and you can see the cancerous cells. What you will see with an EMR specimen or an ESD specimen is the submucosa. You don't see the submucosa well with EUS, but it's only with resection that you will see it. So this patient has a T1A cancer, not a T1B cancer. If it goes into the submucosa, it's a T1B cancer, and the risk of lymph node metastases increases. So performing resection for all visible lesion is a must. If you're not doing it, that is an error, and you should try to avoid that error. What's the data that this is also a good therapy? Because we also perform EMR for Barrett's cancer, and we have 5-year survival data from Germany. 1,000 patients with 5 years of follow-up, and you can see that EMR was successful in 96% of those patients. Recurrence can happen, but less than 15%. Less than 4% required surgery. So you can avoid surgery for T1A cancer in Barrett's, and complications are low, can happen, but they are low. So remember this data, and this is a reason to do EMR. The second error which happens is not achieving complete eradication of Barrett's. What does that mean? If you have resected the lesion and the patient has a C2 M4 Barrett's and you have resected 2 centimeters, there is still 2 centimeter of flat Barrett's which is left. And that is what you should have undergo ablation. You can either do resection or ablation. Which one is better? This is a study from one of my colleagues in Kansas City, a meta-analysis of studies comparing either focal EMR plus ablation, and you can do ablation either with RFA or with APC or something, or you can just resect the entire Barrett's. And so we compared which one is better. What we found was that for complete eradication of intestinal metaplasia, both techniques are very similar. Recurrence also was very similar between the two techniques. What was different is that if you do resection of 50% or more of the circumference of Barrett's esophagus, you can actually run into strictures, and that can cause some problems in your patient population. So always remember that if you do resection, you can do it, but you should start treating these strictures early on. There are some studies to suggest that you can give these patients budesonide, you can give them some early therapy with steroids and inject steroids to prevent these strictures, and that is the data on that. Finally is not recognizing and treating complications or recognizing recurrences. So let's look at that. The first is recurrence after CEIM. What does this mean? looking at all these pictures, these are all recurrences. And recurrence by definition means that you have achieved CEIM. What is CEIM? Complete eradication of intestinal metaplasia, meaning that all the Barrett's is gone, replaced with squamous mucosa. This is what happened in our patient, is it had all gone, but 2 years later, we saw a small island reappear. So this is a recurrence, and you should be careful about it. This is a recurrence of intra or submucosal adenocarcinoma. You can see that this is a small area protruding from below the squamous mucosa, and this is another submucosal cancer. You can see this is something which is protruding out, a subtle, almost a Paris 2A, 2B lesion, and this also can occur as a recurrence. Finally, you can see flat recurrences. You can see abnormality on NBI. This is a recurrence at the gastroesophageal junction, and this is a recurrence of flat high-grade dysplasia. So after you have achieved CEIM, recurrences can happen. On all these endoscopic images, you can see that recurrences come in different sizes and shapes. So always be careful. It's not one way that the recurrences occur. Now, when and where, how do these recurrences occur? This is a meta-analysis of 20 studies, close to 3,000 patients with Barrett's who had undergone BET or Barrett's endoscopic therapy. And the follow-up was quite long. And we looked at the recurrences. Any recurrence of Barrett's over this time period was 15%. Recurrence of high-grade dysplasia or cancer was 2%. What was the location of any Barrett's? Close to the G junction, 56%. In the esophagus, 44%. What was the pattern of recurrence? 50-50, meaning in half the patients you saw a lesion, in the other half it was just flat Barrett, squamous mucosa. How about the recurrence for high-grade dysplasia or cancer? In the G junction and esophagus, again about 50-50, but high-grade dysplasia and cancer more likely to be visible recurrence. So you should know that. So the bottom line is that because recurrences happen, make sure that you have achieved CEIM, and number two, that you are following these patients after achieving CEIM in a surveillance program, and again, that you are taking systematic, clean examination and biopsies from the neosquamous mucosa. The other I shouldn't say a complication, but something we have to recognize right away is after therapy, you could have bleeding. And this is the same for any EMR or resection that you do, but you should be able to control it and you should know how to do it. You can use a soft coag current with the tip of the snare. You can apply pressure with the cap, or you can use a coag grasper forceps and try to do it this way. The issue is, no matter what you do, make sure you take care of the problem which has occurred due to your therapy. Sometimes I see a patient who was treated at an outside hospital with EMR about 5 hours ago, and he comes in with a bleed. And I'm sure that if they did a good examination and looked at the EMR site at the time or finishing their endoscopy, they could have picked it up and they could have easily treated it, and the patient could have avoided a hospitalization and could have avoided a second endoscopy within a span of a few hours because the bleeding was not appropriately managed. So that's an error in the management. So this is my final message. This is true not just for my lecture today, but for all these wonderful lectures that SOBED has been having over the months about errors. Is forget the mistake. Always remember the lesson. So it is good to have a complication, which means that you are doing enough procedures. The good thing is that you recognize the error and remember the lesson so that in the future you do not repeat the mistake or the error. So thank you all very much for your attention. I wanted to keep this brief so that now we can have a good discussion with everyone on the team. So thank you very much.
Protect Sharma, congratulations of the excellent presentation. At the moment, more than 500 people are watching this session. I invite Dr. Dalton and Victor to start moderating this session. I remind colleagues that this session will end at 8:55 as a result of Dr. Sharma's commitment. Dalton, go ahead.
Hi, Dr. Patrick. Very nice presentation. I would like to have some questions, especially about the diagnostics. The first thing that we can see in the literature, and you said in your talk, is about the short Barretts. You think really that we don't need consider or give importance for the short Barrett diagnostics? Maybe we'll miss this diagnostic. Maybe in the future, some patient have a lower incidence, but can have they have a little bit more high incidence of adenocarcinoma. What do you think about the short Barretts? Don't consider, or we need to talk more about this, study more?
No, so excellent point. I think it's a very important clinical area. I would say that overall, as you know, and especially for people, endoscopists in Brazil and in LATAM, we have to understand that the risk of dysplasia and adenocarcinoma in Barrett's is low to begin with. Not many patients. I mean, you will have a lot of patients with Barrett's, but very few dysplasia and very few cancer. The key is to diagnose those dysplasias and the cancer. And the best time to diagnose them is at your very first endoscopy. So make sure that your first endoscopy is your best endoscopy and that you've done the best job possible. I went over the features, and I think this is true for, also if you're looking for early gastric cancer, do a careful examination, a slow withdrawal, look at the G junction carefully. If you see a visible lesion, please biopsy. Please resect if you think and suspect a cancer. My concern about the very short Barrett, which I diagnosed, and I would define very short Barrett as less than 1 centimeter. And less than 1 centimeter means that you open your biopsy forceps, okay? And you are not able to get that tongue within the biopsy forceps. That biopsy forceps is about 5 to 6 millimeter. So that means you're dealing with a very, very short Barrett. If you don't see a lesion, I would not biopsy, because I think you just overdiagnose. The patient gets scared because now you give them the diagnosis of a precancerous condition, and then it puts them unnecessarily a lot of anxiety. If it is the length is between 1 to 3 centimeters, to me that is the short Barrett. That is who you can enroll in surveillance. And if you've done a good endoscopy, you can repeat the endoscopy in maybe 4 or 5 years. And I think that is reasonable.
I have another question about the histologic diagnostics. We have a British school and Japanese school that they don't consider that intestinal metaplasia is necessary to confirm the diagnosis of Barrett esophagus. And the American school recommends that to find intestinal metaplasia is necessary to confirm the Barrett. diagnostic. What do you think about this? This can contribute to decrease our mistakes or errors?
Yes, a good point is, of course, I will have a little bit of a bias towards the American school because I've written some of the papers about it. So I think either way you look at it, I mean, you will have to take biopsies, correct? So you can evaluate those biopsies for both intestinal metaplasia as well as dysplasia or cancer. The key is to find dysplasia and cancer. We can sit and have a big discussion about intestinal metaplasia, but from a practical standpoint, if you have a length which is greater than 1 centimeter, you can enroll that patient in surveillance and take systematic biopsies. And as long as the biopsies don't show dysplasia or cancer, it's good news for the patient. The confusion of the histology arises when people start taking random biopsies from the GE junction. And also the Japanese who use the top of the palisade vessels as the landmark for the GE junction. And at least in the cases in the US, we find that the top of the palisade vessels actually extend into the hernia sac. And those short Barretts truly are not short Barretts. And Vitor knows about it. We had a good live demonstration a few months ago, and there was some concern if the patient had Barrett's or not. And some of the biopsies were being obtained from the hernia sac. So, we have to be careful. So, what I always say that it's important to make the diagnosis of a disease, but as a doctor, it is equally important not to overdiagnose a disease because that's not good for the patient also.
Okay. Can I do one more question, Vitor? After me, you can start your questions, and after we will translate some questions from the audience. It's about the landmarks. You said about the palisade vessels considered by the Japanese, and we have the gastric folds considered for the American school. Firstly, do you think you need to consider the two landmarks, or you think that only the gastric folds is enough to determine the length of the Barrett's?
So yeah, very good point. And in Rio last year at the World Congress of Endoscopy, which by the way, I mean, I had a wonderful time. So I also wanted to thank Vitor and Eduardo and all my Brazilian friends for their hospitality. We had a wonderful time in Rio. So we presented the Rio consensus on Barrett through the WEO, and it was a global consensus. And as part of the consensus, which included Japanese endoscopists and Brazilian endoscopists and endoscopists from Europe, Asia, and America, the consensus was to use the top of the gastric folds as an important landmark for determining the top, as the gastroesophageal junction. So I think it is not anymore just the US school of thought, but it appears also to be a global and a WEO and a global definition and landmark.
Okay, Vitor, do you have some questions?
Oh, yes. So first of all, thank you very much to Sobed and Professor Eduardo Moura for the invitation to participate in this session. It's really a great honor to share this session with Dr. Sharma, really the greatest expert in Barrett's esophagus in the world. So thank you so much for your lecture, Dr. Sharma. And I'd like to make two questions, actually. One is very short question, coming back to the question about the short segment Barrett's esophagus. A practical question. Sometimes we receive a patient that had undergone endoscopy in a different institution, and they have seen that very small, very short irregular Z line, and took a biopsy, and the pathologist say, okay, there is intestinal metaplasia. This is consistent with Barrett. These patients come back for your opinion as a second opinion, repeat endoscopy, and what you see is just a irregular Z line. So, how is your approach? The patient has already a histological diagnosis of Barrett's esophagus. Do you take another biopsy, or you just rely on your endoscopy assessment and you state there is no Barrett's in this situation, and you just uh, give recommendations for the patient about surveillance? Could you share with us your practical approach in this case?
Yes, thank you, Vitor. Again, thank you for asking me a very difficult question because, the guidelines really don't address this very specifically. So my practical approach is that I will repeat the endoscopy just as you did, when the patient is referred from some other institution with a diagnosis of Barrett's. If I see the irregular Z line, just as you're describing, a very, very short, ultra short Barrett's, and I will, for the first time, I will take biopsies. And then I will sit down with the patient with both the endoscopic image as well as the histology and inform the patient that their risk of developing any dysplasia or cancer is extremely, extremely, extremely low. And in fact, the risk of endoscopy may be higher at some point. Most of the patients may come in for maybe one more endoscopy in 5 years, and then they are agreeable to stop the procedure. So, what I do is I discuss it very clearly with the patient. I will tell them that, in my expert opinion, I don't think that this is making a diagnosis of Barrett's. And whether we call it Barrett's or something else, the more important thing for the diagnosis is the risk for future cancer. And I feel that the risk is so low that it is okay if we don't repeat another endoscopy. I'll tell you that I've had many discussions like this with many patients because I get a lot of referrals for Barrett's. And I have to admit that half of my referrals for Barrett's are those who don't have Barrett's. So I've prepared a very nice cartoon for them that I sit and explain to them. And I would say that the majority of the patients will come back in again one more time, maybe after 5 years, for one more endoscopy. And if I document again irregular Z line and no dysplasia, then the patients are very happy to stop any future endoscopy.
Well, thank you very much. And the second question, before we start taking the questions from our colleagues, and I stimulate all of them to send those questions for us. Uh, Concerning the patient, I appreciated your lecture that you mentioned about not missing the dysplastic lesion. And you showed us a case where you were using white light endoscopy. So you never mentioned about the image-enhanced endoscopy or magnification endoscopy for detection of dysplasia. So my provocative question is, can we detect these dysplastic lesions relying only on white light endoscopy and a careful examination? In other words, when do we need the image-enhanced endoscopy? Does these tools all improve our skills to detect those lesions? Could you make some comments about that, please?
Sure, thank you. Very important question. So I would say that a good high definition white light endoscopy is the cornerstone. If you don't do that, then forget about image enhanced endoscopy. So you have to focus. You have to first become a very good white light endoscopist before you can become a NBI or BLI or eye scan expert. So this is the bare minimum. Once you've done that, yes, you can supplement it, but not replace with some of these other image enhanced endoscopy tools. The reason I didn't get into those details, which I try to avoid sometimes, is because people then just focus on the image enhanced endoscopy part and forget about the very basics. And I think we have to recognize the basics before we go in. In my practice, if somebody is referred with a diagnosis of dysplasia or a visible lesion, I will always use a cap at the tip of the endoscope. First, do a careful high definition white light endoscopy examination, as I showed you. 99% of the times, I will be able to diagnose something abnormal with it. And then I switch to one of those image enhanced techniques, including magnification, to further characterize the lesion. So white light endoscopy is good to pick up the lesions as a red flag technique. All the image enhanced endoscopy is for further characterization of the lesion. Is the pit pattern abnormal or normal? Is there dysplasia or not? That is the second step. So I would take a stepwise approach to it. And the other thing also is that for all the endoscopists watching today, is that if you decide to do the characterization, please try to get your skills better by practicing more and more. Look up, some atlases, look up some papers on what pit pattern means what, because you may switch to image enhanced endoscopy, but if you don't know what you're looking at, then it is a waste of your time. So use your time appropriately. So if you want to do NBI or BLI or eye scan, it's excellent, do it, but the steps remain the same. Clean the esophagus, sedate the patient well, do a gradual pullback, use a cap, use the magnification, and then look at the pit patterns, and you should know what the pit patterns mean.
Yes, we
For
have
this,
one question. Oh, I'm so sorry.
Victor,
Go ahead.
Victor,
Go ahead.
getting this matter, do you think that the dyings can improve your diagnostics, especially to find dysplasia, or with the new techniques of image enhanced endoscopy is not is not being so very important to use the dyings? What do you think about the dyings?
Yes, so yes, you can use the dyes as well. The issue with the dye is that it's more challenging because it becomes a little bit of a subjective issue. Is what is the concentration of the dye you are using, which dye you are using, how much do you spray, how long do you spray it for, and how long do you let the dye settle down. So again, if you look at the evidence according to the ASGE PIVI criteria, acetic acid chromoendoscopy or acetic acid dye has been shown to improve the recognition of dysplasia in Barrett's. It's the same concept that you should know what you're looking for. So there is an aceto whitening reaction which happens, in which the area first blanches and then it gives it a nice red color, and that helps in diagnosing dysplasia in Barrett's. So again, just pick one of the techniques, whether it is dye spraying, one of the image enhanced endoscopy, and keep using it until you become an expert. And then, you will be so good at it that then you can start using it very efficiently in your patients.
Yeah, so Dr. Sharma, we start to get some interesting questions here. So the first of them comes from Dr. Lix Oliveira. You know that radiofrequency ablation is not available in many places in Brazil. I could tell you that maybe in a very few centers we have this technology nowadays. And the question is, after we do an endoscopic resection of a focal lesion in the Barrett's esophagus, and as we don't have a radiofrequency ablation, can we rely only on endoscopy follow-up, maybe using techniques like image-enhanced endoscopy for the detection of metachronic lesions?
So yeah, good question. And the scientific answer based on studies is that you should use some therapy to get rid of the Barrett's. And there is a randomized controlled trial from Germany in which they did exactly what the endoscopist is proposing, that you keep following those patients for the development of metachronous lesions. What the study found was that in those patients who underwent some sort of ablation, the risk of metachronous lesions was significantly lower as compared to those that had no ablation. In this German study also, they did not have RFA available, so they were relying on argon plasma coagulation as the ablation method. So what is important is not whether it is RFA or whether it is argon plasma or it is cryotherapy or it is bipolar probe. The important thing is do something. So if something is available, if you have argon plasma APC available, please use that. If you don't have APC and you just have the heater probe or the electrocautery probe, you can do that. If you can do more resection, do more resection, but it is better to do something to treat all of the Barrett's.
I have one question from the audience, Dr. Pessoa from Ceará State. He asking about the Seattle protocol. He said it's not necessary. It's not only necessary to do biopsy of the suspicion lesions, or really you have to do the Seattle protocol.
Yes, very controversial but important question. So taking biopsies of target lesion is the number one important thing. You will find dysplasia and cancer more often in the target biopsies than in the random biopsy. The current guidelines recommend that if you are good with high definition white light endoscopy and some form of image enhanced endoscopy, you could consider only doing targeted biopsies and stay away from the Seattle protocol. So both the AGA and the ASGE papers do recommend that that is something that can be done, with the provision that you really are an expert in image enhanced endoscopy. So if you're not an expert in image enhanced endoscopy, then do the target biopsy followed by the Seattle protocol. If you are an expert, then you can do only the target biopsy, but very good image enhanced endoscopy.
So now I make one question, and I like it very much, the concept that you brought about the personalized medicine. I think this applies entirely to Barrett's esophagus management. And we have two questions, one from Rodrigo Siqueira and the other from Ana Eloisa. They both ask if the length of the Barrett's esophagus makes a difference on your recommendation for your patients for the surveillance. You thought about us a little bit about that in your lecture. Could you share with us about that, please?
Yes. Again, very important aspect, and I'm very hopeful that the future guidelines will specify this. In my practice, what I do is that if somebody has a short Barrett's, and short Barrett's I define as less than 3 centimeter, I bring those patients for surveillance every 5 years. If I have a Barrett's which is 3 centimeters or greater, I bring that patient every 3 years. So in my practice, I do that. And that is still very acceptable to do because the guidelines do recommend every 3 to 5. So you're still following the guidelines if you do for some patients at 3 and for some patients at 5 years.
Hey, Dalton, your turn.
One question about when you do the endoscopy, you have a suspicion of Barrett esophagus, and there is a good inflammation associated. What do you recommend? You do the biopsy, or you prefer to treat the reflux, treat the esophagitis, and after the biopsy in the second time?
So yeah, I do the second part, which is I do not take biopsy at that time. I will stop the endoscopy. I will put the patient on PPI therapy. And if they're taking already once daily, I will increase the dose to twice daily. And then I will bring the patient back in 8 to 10 weeks. And then I will repeat the endoscopy with biopsies at that time once the esophagitis has healed.
Okay, Pratik, I have one question and then another question from another colleague. First, is a curiosity. Currently in the United States, among the endoscopies in the community, how often they report the prior classification in their reports with patients with Barrett's esophagus? Is it common or you seldom see that? Could you share with us?
Yes, a good point. I mean, I would say that in the community, it is less than 50%. And in the academic centers, it is close to about 70 to 80%. So there is a huge difference in the reporting. So, as you know, it is very difficult to change the habits of endoscopists. You know, all of us are all guilty of it. Something new comes, we take years and years to adopt it into our practice. For example, even for the Los Angeles classification, it took 20 years for people to understand the importance and start using it in practice. And even now, I would say, not all community physicians use the LA classification for erosive esophagitis either. So it's a slow process, but through seminars like today and SOBED I'm very happy you're doing this, is hopefully all the people who are listening to this can start implementing it in their practice.
Nice. And I think
We
here
have
is very similar. Very seldom we see prior classification in the report. And just a final question here, Dalton. Dr. Maria das Graças Sana, who is a colleague here from Minas Gerais, she's asking you about some patients with Barrett's esophagus have some inflammatory polyps. Here, I think she is addressing those EG junction polyps that we may see in people with hiatal hernia. Do you have any recommendation for these kind of inflammatory polyps when you have a patient with Barrett's esophagus? Do you remove those polyps, or you just make a biopsy, or just make a surveillance?
So yeah, I mean, I would approach it as any other polyp in the stomach. So anything that is 1 centimeter or greater, I will try to resect it with the help of a snare and send it for histopathology. If it is smaller than that, then I would take a biopsy of it. If a patient has multiple polyps and you have sampled 2 or 3 of those and all of them come back as inflammatory polyps, then I feel much more comfortable that these are all inflammatory polyps and you don't have to remove every single one of them. But at least size, I go by that, and I would resect or snare out the ones which are bigger, 1 centimeter or greater.
Pratek
Eduardo,
Sharma,
Eduardo,
Dalton. Okay.
the last question of the audience here, Dr. Sérgio, he's asking about the follow-up, the patient after fundoplication surgery, and the patient that is having IBP. Is there some difference of the follow-up or the same?
The short answer is it remains the same. Whether there is surgery or IBP, you treat them exactly the same.
Perfect.
Okay. Pratek Sharma, unfortunately, we'll have to end the session. We are all extremely grateful for your teaching. What's your final message to our fellows in the evaluation of the Barrett esophagus?
So my final message is that start paying attention to the quality of your upper endoscopic examination. Don't be in a hurry to perform and end the examination. And every patient coming in for the index endoscopy, that is the key. Slow down, take your time, be careful with your examination, and then start taking the biopsies.
Fantastic. Thank you, Pratek Sharma. Thanks, Dalton and Victor, for the excellent moderation. And thanks for all audience. Now I finalize for the session with 600 doctors to participate for this session because you are the man. Thank you, Pratek Sharma. Bye-bye, all the audience.
Bye-bye.
Okay. Obrigados. Thank you very much.
Thank you.